talk about complications, when I think about complications, I think about things broadly. So I think that poor results is also a complication, and I think that that's something that we should consider when we talk about these things, because I think we talk about complications and avoiding them a lot, and sometimes these are fairly rare occurrences that we spend a lot of time discussing.
Careful follow-up, and you must maintain that relationship, as Dr. Aguirre suggested, because we will be with them. We will not. Some people ignore these patients because they're not comfortable or they don't know how, and these patients need all the support that you can give. One other thing that Sasha suggested is nitrous oxide. I truly believe that helps, and Stella Jasna-Nikova wrote a study on that showing vasodilatory effects of that, but it also decreases anxiety. So using that at the time as well might decrease the use of lidocaine, which is actually a good thing, because then you kind of have still a endpoint of decreased pain. As Dr. Aguirre suggested, pain is sometimes a good endpoint to know about.
I always tell my patients, I'm like, look, we have to work within the confines of reality, and, nobody's perfect and things happen. That's why we plan and we take care of it. So we try and prevent as much as we can. And when we can't prevent it, we know how to manage complications, and I think, that's one of the most important things when choosing a provider is not just can they use their devices, can they perform that technique, but do they know what to do when things inevitably go wrong sometimes? Because you could use the right settings, have the right patient, do the right number of pulses, and they get a burn. And it doesn't make any sense, but it happens sometimes. And so, you always want to make sure you're going to somebody who can handle that when and if it does happen.
And welcome to the Business of Aesthetics Annual Expert Panel Webinar. This empowering discussion will help you navigate challenges, leverage opportunities, and build a thriving career in aesthetics. Thank you for joining us and our panel of renowned industry leaders as they share actionable strategies, best practices, and valuable insights to tackle the unique leadership challenges faced by the aesthetic professionals today. Welcome to our panelists for this webinar. We have with us Dr. Alexander Rivkin, Dr. Kristen Aguirre, and Dr. Stephen Weiner. It is a pleasure to have the three of you with us. Thank you for taking your time and sharing your insights with us.
Thank you for having us, Michael.
Thanks.
Yes, thanks.
It's a pleasure.
So today, with our Business of Aesthetics Expert Panel webinar, we're going to be discussing complication management in aesthetic medicine, how to handle and prevent adverse events. This is a live event, so please engage with your peers, ask questions, and we are confident you will leave equipped with both actionable strategies and that you'll be able to implement immediately. But before we dive in, let me just ask you this. When potential patients in your area search for treatment that you offer, does your practice actually show up, or are they finding your competitors instead? This is a major challenge for many aesthetic practice owners. You might be offering amazing services, but if you're not visible online, you're missing out on a steady stream of new patients. The good news, there's a fix. For real, there's a fix. With the right digital marketing strategy covering local SEO, targeted ads, and funnel-based content marketing, you can not only attract more inquiries, but convert them into actual patients walking through your doors. And here's the best part. If you stick around to the end, we have got something very special for you. Something that can help take your practice's online presence to, I guarantee, to a completely different level. So before we get into our webinar directly, let me just go ahead and introduce myself and our expert panel. And I'll lead off with myself. As I say, my name is Michael Walker. As a leadership coach, professional mediator, and facilitator, I'm passionate about helping set leaders and their teams up for success that matters, helping them lead themselves well so they can lead others well. With a focus on communication, conflict, and change, my team and I at Capstone Coaching help unlock and engage the full potential of an organization and its people. Our first panelist Tonight is Dr. Alexander Rivkin. Dr. Rivkin, a facial aesthetic specialist and assistant clinical professor at UCLA's David Geffen School of Medicine, is known for pioneering non-surgical rhinoplasty. He trained at Columbia, Yale, and UC San Diego before founding Rivkin Aesthetics, focusing on non-invasive cosmetic treatments. A published author and a clinical investigator, he educates physicians worldwide, and frequently appears in national media. His work spans patient care, research, education, and global conferences. Welcome, Doctor.
Thanks.
Our second
Thanks
panelist tonight is Kristen Aguirre. Dr. Aguirre, a board-certified dermatologist and founder of Regenerative Aesthetics and Dermatology, combines dermatology, plastic surgery, and regenerative medicine for personalized care. With advanced training from UC Irvine and Ohio State, she is a master injector and expert in energy-based treatments. A recognized speaker at national conferences and a 2023 top doctor, she is also the 2024 Agnes RF Premier Provider and Dermatologist for the World Surf League. That's interesting. Her patient-first approach is praised for achieving natural, confidence-building results. Welcome, Dr. Aguirre.
Thank you.
And our third panelist for this evening is Dr. Stephen Weiner. Dr. Weiner, a board-certified head and neck surgeon specializing in facial plastic surgery, trained at Johns Hopkins, where he later taught. In 2005, he shifted focus to a non-invasive cosmetics procedures, founding the Aesthetic Clinique, which won Best Aesthetic Practice in 2018. Known for his advanced filler techniques and ultrasound used in aesthetics, he lectures globally on safer injections. A published author and clinical investigator, he was honored with a Lifetime Achievement Award in 2024 and currently leads the Complications in Medical Aesthetics Consortium. Welcome, Dr. Weiner.
Thanks for having me, Michael.
You will now see on your screen the main points for today's discussion that I'm confident will help deliver both an amazing and an insightful webinar. We have some great questions lined up for our panel tonight, and I am looking forward to hearing their insight, their best practices, and certainly their passion. I'd also, as I mentioned earlier, it's live, so I'd also encourage you to connect with us through chat on any questions you might have. You can go ahead and post the question. What I will do is capture any questions you do post. I will get them inserted into our webinar for this evening so our panelists can answer them. If for some reason a question gets posed that we either run out of time, don't have time to post, one of our webinar managers will circle back around to our panelists, get an answer to your question, and get it back to you. So anything you put up will get answered and get back to you. I assure you of that. And if you have any comments or any just a thumbs up or whatever you'd like, feel free to use the comment space. This isn't a one-way communication. We really like to engage our webinar participants. So having said all that, I'm going to stop talking, which is probably a great idea. And I'm going to go and just start jumping into questions. And I'm going to start out with Dr. Rivkin. And the first question I have for you is, as a pioneer in non-surgical rhinoplasty, what are the most common complications you've seen with injectables in facial aesthetics? And how do you recognize and address them to ensure patient safety?
Okay, thanks. That's so it's a really interesting question. It's what everybody really wants to know, and it's a very broad question. I'd like to address it first of all specifically with what we kind of all consider to be complications, but then I include, when I talk about complications, when I think about complications, I think about things broadly. So I think that poor results is also a complication, and I think that that's something that we should consider when we talk about these things, because I think we talk about complications and avoiding them a lot, and sometimes these are fairly rare occurrences that we spend a lot of time discussing. But the more, I think it's important to also just talk about some of the more common things that we see, which are bad results, kind of a results that show a non-aesthetic clinical, non-aesthetic eye in the injection. So So in terms of complications with the nose, as well as other areas, of course, what we talk about most kind of importantly is ischemia, right? So specifically in the nose, but it's caused by, well, okay, sorry. With ischemia, it can be caused by either vasospasm, it can be caused by vascular occlusion. Now, when you talk about vasospasm, you have hyaluronic acid is something that is irritating to the vasculature, whether it's inside the vessel or outside the vessel. So it can cause, proximity cause vasospasms, can cause a transient ischemia that can look fairly alarming, but what goes away relatively easily with massage and heat. And this is, I see, especially in the nose, where it's quite common. For me, it's quite common to see this around the tip area. So, and that's kind of, and I think that that's something that is important. To me, I think it's important to stress to people to not panic when they see the blanching of what they think might be impending ischemia. And that's really the first sign, is this kind of blanch in the skin around the area where you're injecting. It really is vascular occlusion, whether it's nose or other areas. Most of the time, it's something that is that's embolic, but it's possible to have a compressive vascular occlusion in very specific areas. So it's something like the tip of the nose, it's possible. In the ala, it's possible. And in other areas that are very tight around the face, could be possible if you're injecting a lot in the chin, for example. But I'm trying to think of other areas. The tip of the nose and the ala and the columella are really the most common areas you can get compressive vascular occlusion. Otherwise, mostly an embolic event, right? So so the important thing is, again, recognition, early recognition, and quick action, right? Time is tissue, and so you want to prevent this ischemia from going on to necrosis. And so you use hyaluronidase. If massage and heat are not enough, as I think hyaluronidase is quite important, and that's stressed throughout the literature. I think that steroids is not stressed quite as much, but I think it's equally important. I have Medrol dose pack in the clinic. I give it to everybody that I suspect is undergoing any kind of ischemic change, because I think the inflammatory reaction to ischemia and the tissue damage contributes to a forward loop of tissue destruction. And I think that, so then let me say a little bit about prevention. I think that prevention is not, I think that I think we're putting small amounts of filler in vessels all the time. I think we get bruises all the time. We know that we're putting small amounts of hyaluronic acid inside of vessels. So I think that prevention, the most important thing is that you never put a large amount of filler into any one place. So I think you have to be careful with that. You have to be. I don't think there's any place in the face that's completely safe. So I think you always have to have good safety measures and good safety techniques. And for me, this is constant movement of the needle. It's small injections. It's low pressure. And I think those are the cornerstones of preventing vascular occlusion. And I think that some people aspirate. Aspiration is, I don't do it, but I think it's certainly a safety maneuver that can be considered, but you have to do it within, kind of don't rely just on aspiration, do other things as well. Follow other, small boluses, light pressure, that kind of thing. So just have a rational safety prevention protocol. And then afterwards be prepared. You have to be prepared with what you're going to do if something goes wrong. You have to have good, the hyaluronidase that's right there. It's not expired. Steroids. I want to have aspirin around. I like having nitrous oxide gas. I think Maybe it has some vasodilatory effects, Viagra, these kinds of things so that you have everything, set up. So that's the thing that's most concerning to people. Otherwise, in terms of the in terms of the nose, tip erythema can happen, and that's usually most likely an inflammatory response to the filler volume, compressing vessels in the area, causing subclinical ischemia. You can treat it with vascular laser. If that doesn't work, hyaluronidase can be long lasting if not treated. There's persistent tip tenderness, same kind of story, where you can treat it with, if it's really bothering people, you can treat it with hyaluronidase, but it can be long lasting, as long as the filler is in there. Bruising, not really such a big deal for the nose, but can be a big deal if you're talking about the tear troughs. The migration, I really don't find it to be an issue for anywhere, but also the nose as well. I think for migration, it is, I think, a concern about, I think it's from the amount injected in one place. So if you're not injecting large amounts, chances of migration are considerably less. So I think it's another reason to inject small amounts. I think another reason to be, on the move when you're injecting. It's a particularly concern with migration, tear troughs, and lips. Preventing that, I think, we have to talk about small injection amounts. So I don't want to take up all the time with this, but I think that's a decent overview of some of the complications that we see.
I don't think decent would be the word I would use for Dr. Rivkin. I think it would be thorough, might be good. And it was, it's not my field. But you said something right at the beginning. You said poor results, and as soon as I hear that, I think, yeah, that's interesting, because poor results are either real or perceived, and how have you set the patient up for an experience, like you said, the blanching, and like that these things are going to happen, that they're not panicking, that they're not one little thing starts to tip the apple cart right over. It's just something. I'm sure that must be the case, but it must be a real challenge to balance the everything you were describing and all the science of it with the relationship side of it with the person. I can imagine that must be very challenging.
Yeah, you have to talk about it ahead of time, because if you didn't talk about it ahead of time and you talk about it only after it happens, then you're making excuses.
Yeah. Yes. Thank you, Doctor. Dr. Aguirre, the second question is for you. And given your expertise with energy-based devices like Agnes RF, how do you manage adverse events such as thermal injuries or uneven results that can occur during these treatments?
So that's a really good question. And I think one that a lot of people who are, have been using energy-based devices for a long time, as well as people who are kind of just getting involved in energy-based devices, really face. Because, they can be pretty powerful and, capable of some amazing things, but anything that can do amazing things can also do terrible things. And so, I think about it kind of from a start to finish standpoint. The first with anything really is patient selection, making sure that I'm, choosing a patient who is going to be compliant with what they need to do, who's going to follow instructions, who's going to be honest about the medications that they're on, and who is going to have realistic expectations about how many treatments it might take to get those perfect results. I agree about a complication being unsatisfactory results, because when you're dealing with things like RF microneedling, especially the Agnes, and we're doing lifting and we're doing fat destruction, everyone's a little bit different. People have different fat compositions, whether they're buttery, whether they're more hydrated, they may lift better on one side than the other. And so setting expectations about, this may not be a one treatment to get things exactly where you want them to be. And just tell them, this is a process. We're going to see how everything lifts. We're going to see how your fat responds. And then we're going to go in and we're going to kind of gradually even it to where it needs to be. I also do a lot of pulse counting and a lot of topographic mapping. So for example, when I'm using the agonist to eliminate fat in the under eyes or the jowls or the submental, I do topographic mapping where kind of like, well, a topographic map, I do concentric circles where I know my mounds are the highest. Because once you put your topical numbing medication on, the skin swells a bit, and then you do your injectable numbing inside for something like Agnes or skin face tight, or back when we were doing thermage, you know, you're tumescing and it's going to obscure your contours to a certain degree. And I find doing a lot of pre-planning helps to ensure that you're placing the correct number of pulses where they need to go. Thermal injury is going to be a lot about managing the heat. Both, I use a lot of cooling. So we do a lot of Zimmer, a lot of ice packs between sides. I do a lot of manual touching of the skin when I'm moving from side to side. You know, if the skin feels hot, it is, and I want to cool that down before I'm putting additional pulses there. And you can run into a little bit of trouble if the patient is completely numb, because then they don't have an ability to tell you when their tissue is feeling too hot. And so when you're first starting off, really starting within the parameters that are recommended, not going too tight with your pulses, not double pulsing, all of those things are going to be important to prevent thermal injury with things like radio frequency. Now, lasers are similar in that you don't want to stack your pulses too close together because you can get too much heat in between. Or if you're not moving your laser around, if you're doing something with a continuous pulsing, if you're not moving at the rate that you're supposed to go, you can get stacking that you don't intend to do. So, you know, for me, it's cooling, keeping your pulses conservative and your energy settings within parameters until you really know what you're doing and you've got a hang on it. And then realizing that fat absorbs a lot of heat. And if there's not a lot of fat, you can very easily get thermal injury. A classic example is IPLs on the backs of the hands. You know, if you're doing an IPL on the back of a hand on an elderly person who has very little fat there, it's a lot easier to get a thermal burn there than if you're doing an IPL, say, over a cheek, or, you know, on upper arms or thighs. And so just recognizing different parts of the bodies are going to have different capabilities of dispersing that heat as well. And lastly, you know, I always like to consent my patients personally about the risks that are involved with any type of energy-based device. You know, I walk them through, you know, the protocols that we take in order to keep them safe, whether it's eye protection with lasers, whether it's ensuring that we're going to start off a little bit conservatively, and that may mean it takes more treatments in order to keep you safe while we're doing it, and that something is going to take multiple treatments to get where you need to go. So they're not expecting everything to be exactly perfect if that's just not a reasonable thing to be able to promise. And then I tell them, no matter what happens, you know, we're going to stand by you. If anything bad happens, we're going to walk you through it the whole time. And that way they don't have that, you know, fear and that apprehension that something, you know, could go wrong and they'll be left kind of out there on their own.
Thank you, Dr. Aguirre. I hear this, I hear a theme here. I said, and you introduced the, you know, the right patient for what treatment you're looking at, the right pace, both you and Dr. Rivkin are talking about that, and then the right products. And it's interesting, this idea of making sure that people actually hear what they want. I can imagine, you know, somebody has it in their mind that I want to look like that movie star or whatever that might be, or just. But it's interesting. I see this a lot in mediation where I'll have somebody say, share something, and I'll ask the other person, what did you hear this person say? And they'll say something completely different, like not a little different, like really significant. And now we know why we have a conflict. Usually it's because of the definition of a word or the inability to deal with conflict or fear or emotions and all that stuff. But it's interesting. I can imagine in your practices that it must be so important to hear what the person actually heard you say when it says, like you said, you can't expect it to be perfect. And if I said, what did you hear her say? Well, here the doctor said. I said, well, I heard the doctor say it's going to be perfect. Well, no, that's not what she said. And I could see that would be a real challenge in what you're doing, because you've got that, plus you've got all the social media elements that drive perfection.
Yes, I know. I always tell my patients, I'm like, look, we have to work within the confines of reality. And, nobody's perfect and things happen. That's why we plan and we take care of it. So we try and prevent as much as we can. And when we can't prevent it, we know how to manage complications. And I think, that's one of the most important things when choosing a provider is not just can they use their devices, can they perform that technique, but do they know what to do when things inevitably go wrong sometimes? Because you could use the right settings, have the right patient, do the right number of pulses, and they get a burn. And it doesn't make any sense, but it happens sometimes. And so, you always want to make sure you're going to somebody who can handle that when and if it does happen.
Yeah, absolutely. Well, I mean, I deal with in a lot of different medical areas, from veterinarians to dental to the aesthetic side. And the one vessel that's so critical and so highly fragile is trust. And it's such a significant part when you're dealing with somebody's face and the things you're doing. Man, it's amazing the sensitivity you need to have to how you're protecting, investing and growing that vessel of trust. I can just imagine. Dr. Weiner, I've got a question coming up for you. And the question is, as a pioneer, and I think we're not talking about pioneers back when we were hewing logs, right? We're talking something a little different. As a pioneer in using ultrasound for aesthetics in the US, how do you utilize this technology to recognize and manage complications like vascular occlusion during injectable procedures?
Thank you for the question. So the ultrasound has really revolutionized, in my opinion, complication management, all the way from non-desired results to swelling, to just knowing the behaviors of fillers over time. We didn't really know what happens underneath the skin after we inject. But everyone seems to be focused on the vascular occlusion complications. They're actually pretty rare. 1 in 6 or 7,000 injections are vascular occlusions. And I would say that only about 5% of the injectors actually have ultrasound, maybe even less. It's a little more overseas and in South America. So most of the people are actually treating vascular occlusions without having ultrasound. But when you do have ultrasound, it becomes a lot easier. So what you see on the ultrasound is the perforators. So these are the microvasculature that come off of the main arteries. The perforators seem to be the area affected. As Sasha Rivkin was saying, it's a microembolic phenomenon, except maybe in the tip of the nose and the ala where there could be compression. But to say that there's compression anywhere else in the face is not true. So the problem is mainly getting HA or any other filler inside the blood vessel, and then it embolizes it. Actually, there's a new model called the Pulsar that my friends have developed, Danny Soares and Alec McCarthy, that shows when HA gets inside a vessel, it actually splinters and fragments. And so that actually contributes to the problem with HAs. And they get into the very small vessels and capillaries in the skin, hopefully not the eye. And so primarily the focus is finding where these perforators have no flow. It's called a silent area. So what you see in the area of the occlusion is none of that vasculature. But if you look on either side of that area, you see hypervascularity, because the body's trying to help and rescue the area that doesn't have flow. So you get hypervascularity, then you get quiet or silent area. So the key to treatment is under ultrasound guidance is ideal, but it doesn't have to be, is try to aim at those perforators with hyaluronidase. And what that hyaluronidase is several-fold. One is that it obviously can help dissolve the filler in that area if it's HA. However, this treatment is recognized, and I've have treated several non-dissolvable fillers, non-HA fillers with this same technique. So it can't be all about dissolving. There are other actions that hyaluronidase has, which include possibly decreasing the spasm, as Dr. Rivkin suggested, vasodilation, and dispersion. So all those factors help in obtaining higher vascular flow. Improving the vascular flow is what you want. You have this injury and you want to improve it. So I too am a huge believer in steroids, and steroids will decrease the swelling as well as the ischemia and the injury to the skin. So you actually have to do very little, and there's actually papers to suggest this, very little hyaluronidase in the cases using ultrasound, much less than if you were to flood the area like the De Lorenz protocol. And so what you do is you inject 75 to 150 units under ultrasound guidance with a needle in the subcutaneous plane in the area of ischemia. And then you reevaluate it with ultrasound. And if there's improvement in the flow, the patient feels better, there's better capillary refill, you stop there, call it a day, and have them come back the following day and reevaluate. Keep in mind that there are patients who were poorly treated or not treated at all for these vascular occlusions who actually do completely well without any scarring or very minimal scarring. And as Sasha also suggested, there's a spectrum of vascular occlusions where one, we don't even know it's a bruise, and we didn't even know it was a vascular occlusion, to all the way to blindness. So it's not just one or the other, there's a spectrum all along. So we're all in agreement here. And generally, there's supportive measures like topical exosomes, non-injected, topical aspirin, steroids. You get a reperfusion injury, which steroids help as well. And careful follow-up, and you must maintain that relationship, as Dr. Aguirre suggested, because we will be with them. We will not. Some people ignore these patients because they're not comfortable or they don't know how, and these patients need all the support that you can give. One other thing that Sasha suggested is nitrous oxide. I truly believe that helps, and Stella Jasnatnikova wrote a study on that showing vasodilatory effects of that, but it also decreases anxiety. So using that at the time as well might decrease the use of lidocaine, which is actually a good thing, because then you kind of have still a endpoint of decreased pain. As Dr. Aguirre suggested, pain is sometimes a good endpoint to know about. And in the opposite scenario, when you have pain and you improve it, that's a good sign that you're getting better with your vascular occlusions as well. So ultrasound is not needed, but very useful for these cases. One other thing that I think is vitally important that seems to be ignored with some of the protocols is the skin. And I think that injecting the skin on your way out is important because the skin is the end organ, and so most people are injecting below the skin, but including the dermis as well in your injections is important. Then there's the ultrasound pre-mapping. So try to prevent these cases from actually occurring is useful as well, particularly in the deep piriform, in the temple. Some people advocate it for the nose, but I find that to be an exaggerated helpfulness because it's very difficult to pinpoint the very small vessels of the nose. And then to actually draw on a nose that has gel is practically impossible. I think it might be useful for the nasal spine, but Sasha seems to do more than anyone in the country without ultrasound and does pretty well. So ultrasound can't be proven to be safer, but it seems in the right hands, when you know what you're doing, it might be a safer technique.
Thank you, Dr. Weiner. I had never
Yeah.
thought of ultrasound in that context, more of a sports injury. I've had that lots of times playing sports, but I see now we talk about the right patient, the right pace, the right process, and the right precision. Just this idea, it just seems like everything that what's to say? This is a marathon, not a sprint in what you're doing, but it must be challenging because there's such from different webinars and things I've heard, there's such a challenge in wanting to bring in more clients, generating revenues and all those things. There seems to be an underlying risk attached to finding that right balance that you three professionals are suggesting.
Yeah, I do think that the Instagram posts seem to belittle or demean or ignore some of the risks associated with some of these procedures, particularly the nose. The nose is the most common area leading to blindness, which is a god-awful event, like 1 in 500,000 nodes, so it's not that common, 1 in 100,000. So we just need to be real with the patients. Like, hey, I know you want your nose done. However, did you know that these were the risks associated with it?
Yeah, it's almost in humorous ways. So I've got good news and I've got great news. The good news is we're going to do some amazing stuff together. The great news is we need to be wise about it because there is risks. Yeah, it's all in what's Marshall McLuhan said, the medium is the message, right? So Dr. Rivkin, I have a question for you. And that is, when complications arise in your practice, how do you communicate with patients to maintain their trust? Oh, look at that, I already set you up for that. Particularly given your high profile media presence and the expectations it may set. That is a very interesting question. I'm looking forward to that.
Oh, well, I mean, it's, one is, I think when, I don't know, any of these high profile expectations within like 30 seconds or so, I dispel them when I'm in the room. I don't need, I don't need that. I need them to just kind of, see me as a physician and, as a trusted source of information, trusted source of procedures and results. I think, time is trust. And I really think that's the case, right? You have to somehow make the time or try to or optimize the time that you have in the room with the patient. And it doesn't necessarily, I think that one of the things I talk to newer injectors about is how do you get into a room and gain the trust of someone quickly, and where you don't have to take a long time to do so. And I think that sitting down right away, getting to be at their level, not standing up above them, looking them in the eye and speaking to them as you're looking to them with eye contact, which for some people is not easy to do. And so that's okay. But if you're able to do that and you're able to establish that kind of connection very quickly, and in my surgical training, I had to establish those connections very quickly because there's no time. There's like surgery is happening right now. We got to sit down. We got to get through all this information and get going. So being able to establish that kind of connection, I think, is really important. And having as much patience as possible for their kind of what the things that they want to enlist, being able to elicit from them what are the things that they want, that they really desire, because of because the complication that I see most often is they're coming to me and they're saying, I got a rhino, I got surgical rhinoplasty. The guy didn't listen to me. He didn't understand what I wanted. I just wanted my bump reduced. Now suddenly my tip is different. Everything is different. My nose is going off in one direction. This is not what I planned. And I just hear this a lot, over and over and over again. So I think that's surgically is, that's a big issue. Non-surgically, it's a big issue as well, because we really have to, hear them. We have to be able to hear them out. And this is kind of like, I mean, I'm not unique in offering this advice. People hear this advice all the time, but I really think it makes a difference. And just, kind of taking the time, not rushing things, and trying to be as much of an advocate for the patients, as much of a trusted informational source for patients as possible. Because a lot of times I got to, every day I've got to dispel, Instagram myths and TikTok myths about fillers and about, toxins and, all sorts of stuff. So I think that's really, and, and the other thing, one other thing, trust, how to build trust? You say no. They say, like, I want more lips, and their lips are already out to here, and the lips are the first things that enter the room, and then they sit down in your chair, and then they say, I want more lips. Or just, I mean, that's obviously an extreme example, but just having the confidence in your own aesthetic evaluation and your own aesthetic eye, which means that you've trained your aesthetic eye, having the confidence in your aesthetic eye where patient can ask for something and you can say that would not be what you want, because you want to look natural, right? And most people will say, yes, I do. I want to look natural. Like, you don't want to look bizarre, because, there's not the answer to looking, the answer to what we're trying to do is not to make you look bizarre. We're trying to make you look better. So this is, and so saying no, the patients that I've said no to, they bring their family. They bring their husband, their wife, they bring people in, their friends, and saying, this is the guy that said no to me, and you should trust him, because he's going to tell you the right thing. He's not going to, he is going to place your interests above his financial gain.
Thank you, Dr. Irving. I love that. That's it's interesting. We, in my world, we talk about helping somebody. What do you want your story to be in 5, 10 years, something like that? And we think about this. What do you want yourself to look like? And I've heard in these rooms so many comments, like people say, I looked in the mirror, I wasn't familiar who I saw, or I've lost my confidence. And I think there's all these things that are attributable to what has maybe changed in the way they look, or how they feel about themselves. And I think that whole idea of, just to your point, of being real about that, and it's almost like holding up a verbal mirror of what could be. And is that really kind of what I was saying before, is that really what you're saying? And I from my experience, I think sometimes people just don't necessarily have the ability to communicate their authentic desire or passion. They're communicating something that's been thrust upon them because of their feed, or their friends, or whatever that might be.
But also,
the
patients look, and this is very common, because that people, when they look at themselves, they focus on certain specific areas. They see the trees, not the forest, right? And you should be the one that's telling them about the whole context. You should be the one that's telling them, how everything fits in together, and how proportionally it relates to another, because they don't know that kind of thing, and they can't see themselves objectively. They see, they focus, hyper focus on certain specific areas.
Yeah, it's like, how often do we see people that want filler here, and then their nasolabial folds, where they really need it is, mid, upper cheeks and temples. And it's totally. Like, no, you want a V, you're just making yourself heavy, but they're so focused on that one area. And, I always think of my patient interactions as an investment. I'm investing the time, building that relationship, because my easiest patients are the ones that I put the time into in the beginning. And when they say, I want here, and I say, really, what you need is here, they say, okay, you haven't steered me wrong yet, doc, put it where you think I need it. And those are my favorites. And I think it's 1,000% worth the investment. And they refer the best patients, right? They don't refer difficult patients to me. They don't refer problematic patients to me. They almost protect me against their crazy cousin or, things like that. So I think, there are, people want to be, wham bam, thank you, ma'am, in out mills. That's fine. But I think the best work and the most long-term satisfying, lucrative relationships are the ones we spend time with in the beginning.
Along those same lines, it's funny that I do say no a lot, and I keep these patients, and then they come in and what do you think now? And then I say, oh yeah, I think we should do this area. And they really appreciate that now they need it, and they like believe you and trust you. And they said, oh, I must have been really bad for you to do that now. So I'm sure you have that same experience.
Yep.
Yeah,
for sure.
And it's the way every organization, every practice has three spaces: the transactional space about what we do and how we do it, the relational space about who we are and why we matter, whether it be internal or external patients or a team. And then when those two are not working out well together, we have all kinds of unhealthy conflict and tension, and we become an untrustworthy culture. When they're working together, then the creative space emerges where we have courageous conversation, where trust is off the charts and people can't wait to come back and bring their friends. And it's just simply finding the balance in that. The challenge, I think, is in medical practices, because there's so much science, and rightly so, you lean on the transactional side, because that is, you got to get it right. But the relational piece, it takes time, as you've all said, and it's that extra time, Dr. Aguirre, what you're saying. If you make that, this is what they're saying, people don't care how much you know until they know how much you care. And finding that balance, and it's got to be challenging given the nature of what you're doing, notwithstanding the time that it takes. But it's really like a good annuity. It'll pay you dividends downstream. So, Dr. Aguirre, I've got a question for you. As a trusted speaker at a national aesthetic conferences, what best practices do you share with other practitioners to minimize risks and liability when performing aesthetic procedures involving injectables and energy-based devices? Now, we've introduced a new word into that, liability, so I'm interested.
Yeah, so, I think that's a really good question and an important one. Locally, I do help a lot of my colleagues manage complications, both from how do we manage them medically, but also how do you manage not having that complication turn into a complication. And, the first for me always starts with the consultation. I do the consultation in part so that the patient gets to know me, but it's also in getting to know that patient. Do they have realistic expectations? Do they seem, accusatory toward past providers already? Do they speak in a way that it places blame about things that are very common? In dermatology, I hear things like, oh, I had this tiny little spot and they just dug this huge hole out. And it's like, oh, well, what was it? Oh, it was a basal cell. And it's like, well, it's, that person automatically, to me, from an aesthetic standpoint, is they have an unrealistic expectation of what is necessary and what outcome is like appropriate in that instance. And so I do a lot of, almost interviewing them during the consultation to, keep myself protected. That was really hard for me at first, drawing the line between medicine where, ethically, I don't want to deny care. But in aesthetics, this is all elective, which means we don't have to treat anyone that doesn't seem like that's going to be, the right move for either part. So, I some of my best decisions have been to, not take on a patient as into my clinic. I think the next really is about setting expectations, being very upfront about what the risks are. Patients always feel a lot more betrayed, which leads to anger, which leads to lashing out and a higher potential for lawsuits if you are not very clear about what the risks are. When I do, filler and I'm consulting, I always mention blindness. And I think there are a lot of providers out there that are afraid to mention that that's a risk because they're afraid it's going to dissuade those patients from, getting that procedure done. But it's really important that you're honest. And, fortunately or unfortunately, as we've discussed previously, patients hear what they want to hear. They may not always internalize it because they have in their mind that they want this thing already, but you're going to be in a lot more trouble if a complication happens if you didn't mention it. And so I think it's really important to, I always sit down, I look them in the eye, I give it to them in writing, but nobody reads consents these days. And I make sure I go over the most common and the most concerning possible complications and what I do to help prevent them, right? Like, this is a possibility. These are what we do to help make sure that that doesn't happen. And then if a complication does happen, and when you're doing larger volumes or you've been doing this for a long time, you're going to have complications. It's just it's not possible really to not. I always educate my staff on not just what to look for, but buzzwords on if a patient says, I'm having pain, or my skin color looks funky, or it's, swollen for, it's still swollen, or it doesn't look right, or even if they just sound really nervous, I tell my staff, the default should be bring them in. Just bring them in, let's take a look at them. Because even if it's not a complication or if it's something minor, the patient feels like you took their concerns seriously and trusts you and understands that you're there for them. And that can head the problem off at the pass. And then you're getting the opportunity to lay eyes on it early. And as we all know, knowing if we've got an ischemic event early, knowing if we've got a burn early, knowing if we're just getting PIH, post-inflammatory hyperpigmentation, knowing that early on helps us manage that complication more effectively as well. And then I do pretty, close follow-up, whether it's me just making a call in the evening after clinic, if, someone's, got what I call hot spots, if they've got a hot spot and it's just, a little erythema, I'll follow up and make sure that they're feeling okay. And the only times that I've really run into trouble are times that, the patient didn't feel heard, they didn't get access to us, they got, blown off by, a staff member not taking them serious. Oh, that's fine, that's fine. And I think as long as the patient feels well taken care of, that you take them seriously, that you've got their back, that so far for me has been the best protection against liability, because things happen. No matter how good you are, no matter how careful you are, something's going to happen. And so that has worked well for me. And then taking responsibility for it, I think, is also really important. I do a lot of energy-based devices, and periodically, someone's tissue will just retain more heat than expected. And I say, what? It looks like, the tissue has absorbed more heat. It's picked up more of this. We've definitely gotten a little bit more, inflammation and irritation here than we want to, but, I got you. Okay. Like, this is what we're going to do. This is how we're going to handle it. And, I'm with you every step of the way. Denying it or pretending that it was their fault because, they don't follow instructions. I've had a patient not clip their real sharp nails down after a medium depth peel and just Freddy Krueger themselves in the middle of the night. And it doesn't do any good to be like, well, you didn't cut your nails, that's on you. It's like, nope, come on in. I got you. Let's take care of this. But I'm going to make you clip your nails before we do your peel next time. So, I think that you just kind of treat them like people and you take care of them.
Thank you, Dr. Aguirre. As you were talking, I was thinking of the Hippocratic Oath. And, it says in there that you're striving to benefit patients to best of one's ability. You know, I just want to, just a shout out to you guys. It's one of the few institutions I believe that doctors still carry a vessel of trust, that they honor that and they carry it and they care about it. And I think that you guys are just so exemplifying that tonight. Thank you for that. I know that there's a lot of institutions that have kind of lost their trust. We won't go into which ones, but it's good on you guys. I'll just leave it at that. Dr. Weiner, a question for you, and it's with your focus on training physicians and your co-authorship of a textbook on ultrasound and facial anatomy, what protocols involving ultrasound do you advocate for to enhance safety and again, speaking on reducing legal liability in aesthetic practices?
Well, I think that there are certain areas that are less safe than other areas. And we know that the glabella, forehead, and nose seem to be the areas mostly associated with blindness. Blindness seems to be the one that we don't really have a very good cure for, and seems to be the ultimate worst case scenario. So trying to avoid that would be the key goal, because it could really ruin your personal career. So basically, if you're not comfortable, do not inject glabella, forehead, or nose, and you eliminate probably 80–85% of the chances of causing blindness, with or without ultrasound. So ultrasound is perceived as being a safer technique, but there's so few complications that it's hard to really get a significant number of patients to decide if it's safe or not. But in my opinion, there's a couple areas where we more commonly inject, and I think that ultrasound is helpful, which is the temple and the deep piriform if you're injecting it down to bone. And if you're injecting down onto the chin, onto the bone too, those are the areas where probably the most vascular occlusions occur, not blindness, but vascular occlusions occur. So if you pre-screen the vascularity, you can potentially avoid injecting inside the vessel. So in the temple, the way I inject deeply, you do the one up, one over technique that Dr. Swift advocates. You put a little dot there, you take out your ultrasound. Has to be a high quality ultrasound, or you're limited by the quality and you're not sure if there's actually a problem with the ultrasound, or there actually is not a vessel there. But if you have confidence that the ultrasound and your abilities are good and you don't see a vessel on the bone at that area, then go ahead and inject. If you do, alter your position slightly one way or the other, posterior, anteriorly, and do another evaluation. If it's clear, you can inject there. Deep piriform, I look to see if the vessel's on the bone or not. If it's within 1.5 millimeters of the bone, you probably don't want to inject on the bone, because the bevel could be in the vessel as well. In the chin, there's this ascending mental artery. It's usually paramedian, meaning off the midline. So you want to make sure there's not one in the midline. And rarely there's actually a foramen called the central foramen, which even if you're on bone, you could be injecting into a foramen, and that foramen actually connects to the tongue. And there have been cases of tongue ischemia from chin injection. So I'd like to pre-map in those 3 areas using ultrasound to get safer injections in those areas, I believe.
Thank you, Dr. Weiner. And this has been, I'll tell you, for me, it's been fascinating. It's particularly because it's not my field. Now, I just want to give you guys confidence that I'm not going to go out and hang my shingle up and start practicing. You've taken me out of play, so that's good. I was thinking about it, but no, not now. No, I'm just kidding. But I do recognize that our time is coming to an end, and I want to just share my screen here. Thank you very much. And let me just, you guys, it's been awesome and just so much depth. I mean, incredible depth and great ideas. But as you recall, I think you recall, I promised you a very interesting gift, and here it is. It's a gift from the founder of the Business of Aesthetics Expert panel webinar. His name is Narain Arora, who is the CEO of Equa Marketing. And Equa Marketing, if you're not familiar with them, they are a digital marketing organization for doctors and medical professionals. As a token of our appreciation of your time and your participation. By the way, thank you. All the back and forth comments that were going on, I didn't pose them up as questions because it was just all kinds of content that was clearly related to you in your specific fields, and I hope that was insightful for you. But this is really as a token of our appreciation of your time and your participation. Narain is offering you a free marketing strategy meeting with Lila Stone. Lila is the Business of Aesthetics and Marketing Director for Equa Marketing. Lila has established herself as a trusted expert in digital marketing and is passionate about empowering medical professionals with the marketing tools and knowledge to stand out in a competitive market. You can see from the slide in front of you that Lila has considerable specializations. And this gift, as I say, is what Narain really likes to do. He loves to support this area of endeavor. It's been his passion. And if this is an area, most of us are not digital experts. And just like we've been talking, like tonight we've been talking about the right patient, the right pace, the right process, the right precision, the right professionalism. That connects right into the marketing. This is an opportunity where Lila is going to spend 5 or 6 hours just examining, kind of, to use Dr. Weiner's word, doing an ultrasound of your digital footprint and having a look at just what is there, what's happening, what's not, what could be happening, and then coming back to you with a report that you'll be able to implement and utilize. And as I say, there's no cost to this. You'll be able to you can go ahead and scan the QR code you see on the screen if you're not using your phone for the webinar. Otherwise, it's in the chat. That link is in the chat. You can click on that and book your a meeting with Lila. I can tell you, it adds so much value. I mean, Google makes like 6,000 changes a year to their logarithm. So trying to keep up is a challenge on the best days. So I always look at an opportunity like this through 2 questions. The first question is, what's at risk to do this? Well, it's just your time, which is valuable, super valuable, and I appreciate it. But that's it. There's no hidden cost to this. The second is, what's at risk not to? Well, you need to weigh that based on how satisfied you are with your digital presence and your customer platforms, and in particular, just how your practice is seen in the marketplace, specifically in the areas of your interest. So I'll leave that with you, but I want to then just shift gears and just say thank you. Great pictures we have of the 3 of you. Thank you for our expert panel, Dr. Alexander Rivkin, Dr. Kristen Aguirre, and Dr. Stephen Weiner. So much insight, best practices, and certainly actionable content. Collectively, you've made the complex simple for professionals, not me, the hidden visible, and the difficult easy. And that is no small feat. Secondly, thank you to all our attendees for the privilege of your time and your participation. Without you, we don't grow together. And when we don't grow together, we don't set each other up for success. So let's keep doing that. A reminder to like, share, and review us on your favorite social media. We love likes and shares. You should as well. And be a part of someone else's success. So until next time, and on behalf of our panelists, keep striving for excellence and exceptional patient care. Mike Walker, till next time. Thanks.